This last unit of study is on fluoroscopic dose and safety. It's pretty text heavy as well as it does have a lot of pictures. So, the objectives are that we're just going to talk about some of the ways that we can keep patients safe through using technical factors or geometry of the tube itself and some of the other safety mechanisms that are regulated or designed into the equipment and required by government agencies. So, the Image Gently was the first campaign developed by the American College of Radiology to begin to lower radiation exposure to pediatrics, especially in CT imaging. The Image Wisely was developed shortly after that, specifically for the practice of radiation safety in adult images. Those two websites, there's websites related and they have so much information on them. And if it's something that you're concerned about or want to be part of, you should check into it. The dose delivered is highly dependent on the operator of the fluoroscopic equipment. There is special awareness and knowledge of technical factors that are needed to choose to keep the dose low. There's certain principles that need to be followed, and you need to limit the fluoroscopy on time. Those are just a few of the main ideas. Time, distance, and shielding are the fundamentals of radiation protection. The number of images required always relates to using a pulsed or a frames per second mode. As we talked about automatic brightness control in the last module, technologists can choose the technical factors in a dose mode on some C-arm units. The FDA has compiled a list of documented radiation-induced skin damage, and the International Commission on Radiologic Protection, the IRCP, reports that skin burns threshold is about 2 gray, with an onset 2 to 4 hours after exposure. And then at 1 to 2 gray, cataracts begin to develop within 5 years. Fluoroscopy equipment has evolved to protect the patients and operators from this unnecessary exposure over the last 100 years. Recall that timeline from the first unit of study. We used fluorescent screens, mirrors, optics. We started to use more lead protection devices. Then image intensifiers came on the scene, adding charge-coupled devices, and now we use flat panel detectors for some specialized imaging. So these things have improved the image quality, which has, again, just increased the use of fluoroscopy because it is so good. But now the dial's being turned back as the dangers of radiation become more well known. And that's, again, where those two campaigns of Image Wisely and Image Gently came into play. So these next few slides will be of charts that explain dose relationships. The first one is about annual radiation dose limits for occupational workers as well as the general public. And you're going to learn this information in radiation biology in the fall. So it's not going to be included on a test in this class, but I do want you to be aware of it as a reference point. So now we'll look at the doses for common diagnostic exams. Again, use this as a reference to put things in context. And this table uses the equivalent of the exposure from one PA chest x-ray to compare that to fluoroscopic doses. So these are interventional procedures which usually have longer times, but even though they don't mention the fluoroscopy time, but it seems like these are the average exposures used. So suppose for an AP KUB on a large adult male, you choose the factors of 600 MA and a tenth of a second at 80 kV. The entrance skin exposure, or ESE, to that patient would be about 1 Rankine. If the same 600 MA current was used to image the same adult male with fluoroscopy with 10 minutes of beam on, the ESE would be 5900 Rankine, and that definitely would result in a serious skin burn. An actual fluoroscopic exam using an image intensifier on the same male would use a 3 MA current for about 10 minutes, And then the ESE to that patient would be about 30 Rankins. The total rate of exposure would be lower using the small current of 3 MA, but the total exposure to time to the patient would be higher. The static images need way more photons to create an image as in diagnostic radiology. The dynamic imaging uses far less photons produced at the 1 to 5 MA to be able to produce an image that is bright enough to see. The fact that radiation is not seen often gives operators a false belief that it's not really there. This image can be used as a reference when you're thinking about C-arm use in the surgical suite. As you notice, the X-ray tube is under the table, which protects your eyes and chest the best. The middle area has high exposure no matter which way the tube is, and we know that the X-ray tube itself has protective lead shielding around it that limits scatter and leakage. So the same image with a lead curtain attached on a fixed unit would also lessen the middle exposure. Protective equipment always should be worn, of course, and lead aprons are examined for cracks annually at a minimum, and that's the recommendation by the Joint Commission and the American College of Radiology. So keep in mind that standing next to the patient exposes the operator to 3 milligray an hour or 300 Rankins per minute. So this image gives us a better view of keeping the image intensifier or receptor close to the patient to lessen scatter. Using a lead curtain would help here as well. The dose mode mentioned earlier allows a technologist to choose between high, medium, and low doses. The normal mode is naturally the most chosen one because it delivers the average exposure needed to keep good image quality. High dose mode is also known as boost mode, and it's needed to visualize how low contrast areas that require details to be seen, such as when using small catheters in vascular imaging. High dose mode is found to produce entrance skin exposure rates of 10 to 20 Rankins per minute versus 1 to 5 Rankins per minute in normal mode. FDA rules allow for up to 20 Rankins per minute when high dose mode is used, but has regulations that relate to the circumstances in which it can be used. Interestingly, a study published in the text Radiation Protection in Medical Radiology extrapolated data to show that high dose mode could cause significant skin damage with 10 minutes of use, while it would take 1 hour and 42 minutes in normal mode. So pulsed fluoroscopy exposure means that short bursts of exposure, 3 to 10 milliseconds, are used for visual checks rather than keeping the exposure on mode. This is sometimes referred to as intermittent fluoroscopy. And so this chart shows the different pulses at 15 or 7.5 pulses per second. And you can visually see these dose reductions. The exposure is about 1/2 the original pulse. So also as a reference, pulse per second and frames per second mean the same thing. So if we keep this in perspective, regular television project images to us at about 30 pulses per second. There is some equipment where if you reduce your frames per second, it doesn't necessarily yield a proportional reduction in exposure due to some override functions that are designed in by specific manufacturers. Digital imaging and flat panel detectors have that design has allowed some features that reduce patient dose for fluoroscopy exams. Digital units have allowed for a continuous mode fluoroscopy, and that means that the tube under the table that's similar to a general X-ray tube. It uses high MAs in the hundreds, such as 2 to 300 MA. Extremely short bursts of exposures are made with the tube cooling in between the bursts. It usually has anode rotation speeds of 10,000 revolutions per minute to cool it off. The computers put images together, which is similar to a digital subtraction technique, meaning that they kind of layer some of those images on top of each other to make the image in the end. It has been questioned in studies whether using these higher MA settings at short bursts, do they really reduce the dose? And they also need to apply additional filtration in these modes to limit the low energy photons. So last image hold is used to retain the last image before the exposure goes off. And if you have this feature, there's usually two monitors, one that has the dynamic image on it, and the other one with the last image hold displayed. So this feature can reduce the beam on time by 50 to 80% because re-exposure to visualize placement is not necessary. So here's some other radiation protection features that are incorporated to keep patients and the occupational worker safe. The source to skin distance of the X-ray tube needs to be 38 centimeters or 15 inches minimum. MA increases as the distance between the source and the IR increases. This is the inverse square law applied. So in examples, if the source skin distance increases from 20 centimeters to 40, which is doubled on a 20 centimeter thick patient, the entrance skin exposure decreases from 128 milliroentgens to 72 milliroentgens. There's also a Bucky slot that refers to the space that opens when the Bucky is moved to the end of the table in fixed units. The space should have a cover of about 0.25 millimeters of lead equivalent. This normally moves into place automatically. All fluoroscopy has a dead man switch, and that means that pressure has to be applied to be able to activate the exposure, whether on the console or as a foot pedal. Timers need to make an audible beep at 5 minutes, and they need to be manually reset. These exposure times are recorded for each examination by the technologist. The dose area product provides information regarding radiation risk. So a meter that's radiolucent is placed below the collimator on the tube to monitor the radiation output. At 80 kV, the rate should not exceed 2.1 roentgens per minute. Dose area product meter readings may need to be documented in the future for all fluoroscopic exams. This graphic demonstrates the intensity of radiation by the varying shades of pink on the left image. The right image shows scatter in a different way. The best advice is to stand behind the radiologist. The 90-degree angle is where the scatter is highest, and it's also at the level of the operator's gonads. It's been said, when your eye is not on the screen, your foot must not touch the pedal. So most systems have at least 3 and sometimes as many as 5 electronic magnification modes. And each, of course, has its own unique dose level because an increase of magnification increases dose. So when we look at this and we're trying to figure out what the dose is, the rule of thumb is that the radiation dose to the patient increases by the square of the ratio of the image intensifier diameters. For example, if the entrance skin exposure is 100 units for a 23 centimeter field of view, the radiation entrance dose increases to 235 units when the field of view is reduced to 15 centimeters. So this slide talks about the safety regulations for patients and the different exposure rates, minimum and maximum. And if you see this example, you can see that the tube actually in the bottom image is moved around to be able to protect the patient. Body habitus really affects the amount of scatter to the worker as well as the dose that needs to be used to obtain the brightest image. The bigger the patient, the more exposure. When spatial resolution is not a key factor, do not use the magnification mode because that mode always increases dose. Flat panel detectors do use less dose, so it may be something to consider if you're buying new equipment. Digital magnification can be also used as a post-processing function, meaning it's applied to the saved image and it's viewed again to kind of problem solve an image. This function is sometimes referred to as the replay zoom feature, and that serves as a protection for the patient because we're not going to re-expose to see an area closer. So this patient had an angioplasty procedure, and about 90 days later, while the patient's on vacation, he complains of back pain. There's this dry reddish area seen in the area of pain, and this continues to worsen over time, becoming more reddened. At 60 to 90 days past the angiogram, the area opens up. The IRCP reports that radiation dermatitis appears several months to years after exposure from an accumulated dose of 10 gray. Cardiac procedures are the exams with the most risk for this to occur because the source is close to the patient. Much spatial resolution is needed for these exams and the part is small, so magnification mode is often used or boost mode to see the detail. It is determined that the patient received 2 gray, they need to be followed. So this patient developed this wound on his right back after some angiography procedures. And if you notice the tube angulation, a couple things are happening. One is it's going through the thickest part on a diagonal, so more tissue is needed to be exposed, as well as an increase of dose because of that angle. And there was really no reason for his arm to be part of this attenuation process. So just be sure when you're positioning patients that you're not hitting anatomy that does not need to be irradiated. Right. So this is the last one that showed the biological effects of radiation. And some of these things can be prevented by just moving the tube in different areas throughout the procedure, as seen on slide 17.